Well, now it is my pleasure to introduce Edwin Lindo and Dr. John Vassall. Dr. John Vassall is our Associate Dean of Clinical Education at WSU. Actually, Dr. John Vassall here is one of our faculty members here at the Elson S. Floyd College of Medicine. Dr. Vassall completed a Master of Science and receiving a Doctor of Medicine at the University of Washington in internal medicine training at Grady Memorial Hospital, Atlanta, Georgia's public hospital. His clinical career includes private practice in Decatur, Georgia, managed care medicine health cooperative, a shared private practice in Seattle with Rayburn Lewis, a multi-specialty group practice at Minor and James Medical, with extensive leadership acknowledgements, including being a member of the Board of Trustees of the Washington State Medical Association, Washington State Hospital Association, and the American Hospital Association, and the Institute for Diversity and Health Equity. And along with Dr. Vassall, we have Professor Edwin Lindo. Professor Lindo is the Assistant Dean for Social and Health Justice in the Office of Healthcare Equity at the University of Washington School of Medicine. Professor Lindo brings in the interdisciplinary study of critical race theory, Latino and Latina critical race theory, and others to medicine and law, so we can better understand how racism detrimentally affects our health, our learning, our teaching, and justice. As a faculty in the Department of Family Medicine and affiliate faculty in the Department of Bioethics and Humanities, Professor Lindo has developed curriculum and teaches critical race theory in medicine and provides student and faculty development around the issues of race, equity in medical education and patient care. Professor Lindo and Dr. Vassall, thank you so much for joining us and the conference today. And it is an honor to have you both presenting. And last and not least, I thank you for all of the work that you do that the bios will never cover. The work that you do in our communities, the work that you do with and for the people, and also your commitment to doing what's right, even when people don't agree with it, and even when when times are hard. And last, and definitely not least, thank you for being mentors and brothers.
Thank you, David. I also want to give a quick intro. One, a big thanks to the organizers. This conference is one that I've attended over the last 5 years, and it is exceptional. David and team have brought folks together, the community together, to continue this conversation when other places and other universities are shutting these conversations down. But the other highlight I want to make, just in case the 184 of you who are on here don't actually know, but Dr. John Vassall is a legend. He is a legend who has provided, as David mentioned, so much to us, so much to the junior folks, to the folks that have been in community. But I always have to say when I present with them is that you are witnessing someone who's done everything that we've dreamed of and is sharing that knowledge with us, right? Starting a Black clinic in our Black neighborhoods, making sure that our communities were taken care of. And yet he's still in the struggle and in the work to make sure that we don't let go and let up. So Dr. Vassall, thank you so much.
Thank you, Professor Lindo. When people call me a legend, I say, wait a minute, I'm still alive.
You're a living legend.
But thank you. And I want to get into this presentation. Professor Lindo and I have done this presentation before. I love presenting with him. Sometimes we get carried away, but we want to try to keep it limited so that people can get involved, because we can riff off of each other and start enjoying ourselves and sort of let this thing get out of hand. So let me share my screen and get into presentation mode. And hopefully everybody can see that. Professor, can you see that?
We're good.
Okay, great. I want to start this off by talking about the medicalization of racism. And what is race? What is racism? Because, you know, we use these terms and we don't always define what it is we're talking about. Here are our credentials, and we can get back to that later. And I want to mention that Elson S. Floyd was the first African-American president of Washington State University. This school is his namesake. This school was founded by him after much struggle to get this done because there was a lot of opposition. But this medical school has come to fruition and is graduating excellent physicians, many of whom are coming back to the state of Washington to practice, which is what the aim and goal of this medical school has been from the onset. So I'm going to say a little bit about African-American history as I'm talking about this, because African-American history is American history. What is race? First of all, racism preceded race. The concept of race, of a Black race, came about during the trafficking of African peoples in the early 1400s. Initially by the Portuguese, later by the Spanish, the French, the English, and millions of individuals were moved from Africa to South America first and North America, most ending up in South America and Central America and in the Caribbean. Race is a fiction. It was invented to justify the treatment of these individuals. In order to justify the way these human beings were treated, it was necessary in some people's minds to define them as different, as a different species, as a different form of existence, so that they can be taken advantage of. So racism occurred before the concept of race. For hundreds of years, there were biblical references that were used to justify and rationalize racism. Now we're in a phase where we are trying to use science to justify, to sort of backfill this idea of race that came out long before the science, the so-called science of racism occurred. So is race genetic? Well, genetic science was not developed until the 1800s, mid-1800s, when a monk named Gregor Mendel did experiments on peas, actually, where he was able to define that something was being transmitted between these peas, and that if he paired them in a certain ways, he could get certain traits. He can get certain color of the leaves and the flowers, and certain fruit from these plants by manipulating how they were fertilized. And from this, he concluded that there's some discrete element that were later called genes that were being transmitted. This idea further was developed again in the 1800s by Charles Darwin, who published Origin of the Species and talked about natural selection, which we call evolution, demonstrating how these genes can be transferred genetically through heritage. But again, this science came hundreds of years, 400 years after race, the Black race, was invented. I love this picture. These two women, that's Marcy to my left and Millie to my right, have different trajectories, let's say, in society. Those who are identified as white women have a maternal mortality of 14.7 deaths per 100,000 live births. Women who are identified as Black women have a maternal mortality of 37.1 deaths per 100,000 live births. And depending on how you measure maternal mortality, this is at least twice the rate, in some measurements, 3 times the rate of white maternal mortality. Infant mortality, 4.7 deaths per 1,000 live births for white women, 10.9 deaths per 1,000 live births for Black women, at least twice the rate of infants dying. Hypertension, the prevalence is 25.6% for women identified as white women. Hypertension prevalence is 39.9%, about 40% for women identified as Black women. Diabetes, 6.6% diagnosed in white women, 12%, about twice, in Black women. Overdose deaths, this is interesting, 21.3% higher in white women, 18.8 deaths per 100,000 in Black women. Suicide, 7.9 deaths per 100,000 in white women. Suicide deaths, 2.8 per 100,000 Black women. Life expectancy at birth, 81 years for white women, 77.9 years for Black women. Now, is there a genetic reason for this? Is there something about the genes of Black women and white women that cause this problem? And the answer is no. The way I frame this is that these numbers don't represent who these individuals are. These numbers represent what happens to these individuals in our society. So in terms of genetics, on the left is Marcy Biggs, is her name, and on the right is Millie Biggs, and they are twin sisters. They are what we call dizygotic twins in medical speak. Monozygotic twins are twins that start out, they're also called identical twins, or twins that start out as the same single cell zygote, and which splits and forms two individuals who are genetically identical. Dizygotic twins are twins who start out with two separate ova that are fertilized and develop in two different individuals. And they are brothers and sisters. They are siblings, which means they're as close as any other siblings, but they're not identical. They used to call it fraternal twins, which makes no sense because fraternal is male and these are not males. So why is it that Marcy on the left will have a different outcome from her twin sister, Millie, on the right? Is this something that has to do with the genes or not? I also like this picture. This is their dad, Michael. They got hung up on the M's, I guess, Millie, Michael, and Marcy. But you can see the family resemblance, especially the nose. I love this. So they are not part of different races, and yet they are treated as different races. And in fact, from a medical point of view, until fairly recently, if Marcy on the left was developing renal problems, kidney problems, her renal tests would be judged on a different standard than the renal tests of her sister, Millie, if she were to develop renal problems. There was an actual different formula that was calculated for their glomerular filtration rate, which is how well the kidneys work, based on race, which, as you can see, makes no biological sense. And yet, even as I read the medical literature, there's still a lot of attempts in the literature to explain what's happening with individuals based on this concept of race. So what are we to make of race? Is race legitimate or is it not legitimate? Race is not biological. It is a social, economic, and political classification. Is it ever legitimate to use race? The answer is yes when it comes to demographics, no when it comes to biology. And here's my illustration. I was reminded of the great curb cut caper. People are familiar with curb cuts now. They are these ramps that they produce, that they engineer into sidewalks. Now, where did those come from? Back in the 1970s, there were a group of disability activists led by a guy named Ed Roberts, they were petitioning San Francisco to put ramps on sidewalks so that people in wheelchairs could access the sidewalks, because otherwise they needed somebody to lift them over it or pull their wheelchair over it. This was falling on deaf ears. So what they did on the cover of Night was they actually produced these ramps throughout the city, and people would wake up and there would be these ramps, crude ramps made of concrete and asphalt on some of the sidewalks. And that allowed people in wheelchairs to access the sidewalks. But what happened? Eventually, the city said, okay, we'll actually install them ourselves in a safe way. And ultimately, legislation was passed that made this a requirement under the Americans with Disabilities Act, and in fact, preceding the Americans with Disabilities Act. So this was actually sort of a affirmative action, where they put in place something that would benefit a particular demographic. So it is legitimate to look at a group of people, in this case, people who are in wheelchairs, and to see that they behave in certain ways, they have certain needs, and there are certain outcomes. An interesting thing happened after they put in these curb cuts. It turned out that a lot of people benefited, not just the people in wheelchairs. People who were pushing their infants around in baby buggies and strollers, delivery people who had things in hand trucks and wheelbarrows and had to get up on the curb. All kinds of people benefited from this, and so it became universally used and employed, and now required by law in some places. So what does this illustrate? That there are certain demographics, there are certain groups of people who behave in certain ways, who have predictable outcomes, and who can be studied and approached and their lives improved. Such is the case for Black folks and Hispanics and white people and indigenous people and disabled people and old people and young people as a demographic group. But no one would make the argument that there's something genetically different about people in wheelchairs that makes them biologically more susceptible to the effects of curbs, and therefore they need to, this needs to be addressed in such a way that this group, this race could be benefited. And that's how the demographic of race is even used now and misconstrued as a biological phenomenon. So from a demographic point of view, from a public health point of view, it certainly is legitimate to use race as you would use disability or age or urban or rural as a demographic to be approached in that way. But to think that this all comes back to genetics is actually on its face absurd. And yet when you read the medical literature, this is still inculcated in the medical literature. So that's my brief introduction to race as a biological concept. And then I'll turn it over to Professor Lindo.
Thank you, Dr. Vassall. I'm appreciative for that foundation. My goal, hopefully, is to elaborate and hammer home a lot of the points that were already made. And I'll share my same slide, but I'll control them here. And I also want to add, if y'all have any questions, you have anything that comes up during this conversation, please put it in the chat or in the Q&A, and we will do our best, as long as I see the red dot, to take a look and answer those questions along the way, because what we believe truly is that this dynamic practice of learning is that we're learning by doing the work. And so Dr. Vassall shared with us the importance of delineating, making the difference between biological understandings and social understandings, which I'm going to dig into more. But it's important for us to, if we're talking about science, right, it's important for us to define things, right? Biomedical papers define things all the time. But if you were to look at PubMed and you search just about every piece that is published in the Lancet, in JAMA, in any of the major medical journals, almost all of them use race as a variable in the studies or the research that they did. However, the vast majority of them do not, I'm going to repeat, do not define race. You may or may not have noticed that, but they do not define it. They use race. But there's a reason why they don't define it. It's because it is excruciatingly unclear on how you would actually, as Dr. Vassall was mentioning, use race as a biological marker or variable determinant of one's ultimate physical outcomes. So what does that mean, Edwin? Make it plain. So there is an individual by the name of Carl Linnaeus. So I'm taking this way back, right? When you see years that start with 17, you're like, Edwin, that's too far back. What's the point of that? Why should we be worried about the racism that is existing and taking place today? Well, it's really because I'm a believer that if we don't get to the core of these vestiges, of these beginnings, then we don't actually start to address the racism that we see today. Because this racism doesn't operate in a vacuum in 2024. It operates in an arc that came from the origins of what was established, as I will lay out here, through Carl Linnaeus. Carl Linnaeus is someone who many of you have taken biology or in high school. You'll remember this name. This is the individual who was effectively the one who named just about every flora or wild animal that you can imagine. He created the different categories, the different species and subspecies. And he was a Swedish physician, botanist, zoologist. And he said, you know, I'm so good at naming these things. I should name humans. That's just a logical next step. And he did, or at least he endeavored. And he labeled what he called the 4 varieties of human species. And I want you to look at these, and I want you to look at them closely. Which one on here does he, and these are taken verbatim, I did not edit, I did not paraphrase, which one on here is presented in the most positive light? You can comment. So we're getting comments. Thank you for the comments. European. I usually would ask folks to say it with us, but you're not able to at this moment. So I'll read it. The European. White, sanguine, brownie with abundant long hair, blue eyes, gentle, acute, inventive, covered with closed vestments and governed by laws. Let's be clear here. What Carl Linnaeus is doing is effectively, and it's multi-pronged, he's effectively identifying and naming himself. He's creating a racialized, it's not, yes, race. He didn't use race as the descriptor. He used color as an adjective of the people, but he is getting so close to it. And he's saying that if you are part of this group, that you are abundant, you have abundant long hair, you are cute, gentle, inventive, and covered by closed vestments and governed by laws. He is creating a taxonomy based on these racialized groups. And it's clear who was at the apex of this taxonomy. But when you, I'm taking you into the sociological world as a critical race theory scholar, my hope and my goal is for us to realize that you all have the tools to engage in critical race theory. Some of you on here, and we'll talk more a bit later, are saying, well, I don't know what it is. And in the news, people are saying it's bad and it's indoctrinating our children and that, you know, I'm a critical race scholar, so I must be public enemy number one of the United States because I want the country to burn. Critical race theory, in short, is effectively observing the realities that we exist in, to name it, to articulate it, and then to find and articulate ways that can dismantle the inequities that exist within that system. Or to put it in another way, like James Baldwin did, is that we care enough to critique it. That is, we care enough about this democracy to critique it so that it can actually be better. And here, he creates the ladder. And at the top of the ladder, he says, you must have white skin, you must have abundant long hair, blue eyes, and you carry these very special characteristics, gentle, acute, and inventive. Now it's labeled as only belonging to this group of people. And then, therefore, to be at the apex, you must be governed by laws, right? So what he's doing is he is in real time, by publishing this work that was peer reviewed, he is not only identifying the apex, but by doing that, it also means he has the power to create the other. There's power in creating the other, to have the authority to use language, to push and create the other and say, I am not you. Dr. Vassall mentioned the identity of Blackness. Let's be very clear that whiteness came because it was situated as the other of Blackness. Right? The term used by the Portuguese in the 1400s was negro, i.e. Black. And therefore it was, well, we must be the opposite of you. Therefore we are white. I saw that someone had a hand up and I'm not sure how to get them their questions. Crystal Roberts, are you able to unmute? Oh, maybe not. If you have a question, maybe you can put it in the comments and I can review it.
Accident, apologies.
Oh, go ahead.
I didn't mean to raise my hand. Apologies. Thank you.
Oh, no worries. Thanks, Chris. So we then look at the other groups, and I want us to look at how Carl Linnaeus talks about Black folks. I'm not going to read it because it is angering, it is destructive, but even more scary is that these are stereotypes that you can still find today in 2024. We can go on what is now X and what used to be Twitter, the darkest spheres of our society. And you can find these stereotypes. And people say, well, where do stereotypes come from? I'm showing you. It comes from the medical publications of not too long ago, of an era where Carl Linnaeus and the others that I'll show shortly were the premier eminent scholars and physicians of the time. But this is not an accident that Europeans sit at the apex, creating the racial hierarchy. You see how he talks about Native folks under the category of Americanus, how he talks about Asian folks under Asiaticus. But he does this thing at the end of each one where he says, Native folks are regulated by customs, Asian folks are covered with loose clothing and ruled by opinions. And he says of Black folks that they anoint himself with grease and governed by caprice. Again, creating the other. Therefore, if you are not this, I have the power to push the other, because this is creating the foundation to be able to say, because if we ask the question and go back to the Jim Crow era South, when buses were segregated, pools were segregated, kitchen counters were segregated, schools were segregated, I sit down and I ask the question, for what purpose? And we know the answer. It is power, creating racial division, creating racial isolation, creating a subhuman group through the other, creating a group that could be the forced labor. But what was the actual rationale? There had to be a rationale. You could have those things without saying you can't eat at the same table. So what was the belief that people can eat at the same table or swim in the same pool? It was that there was groups of people that were physically, biologically, socially, and intellectually inferior. These mechanisms that we're seeing today, or that I'm showing you today, are the beginning scaffolding of the logic of the white logic. And I'll keep saying whiteness as a structure, whiteness as a system, whiteness as a logic, a way of thinking that creates the other, but the logic starts to fall on itself very quickly. Why? Because if the logic is that there's groups of people who are biologically inferior, i.e. they are more sick, or they may shift sickness onto us, or we can't swim in the same pool, and this is true statements that have been articulated. We can't swim in the same pool because blackness's skin is going to wash off and it might get into or onto the white skin, or that you shouldn't intermarry because it's quote unquote harming the race, right? We can go on, but it started somewhere, right? The logic started. But the logic needs a definition. And interestingly enough, there wasn't one. And I'll show us quickly here. So we look at John Blumenbach, also a doctor and German scientist and anthropologist. He starts creating the racial categories as we know it in any quote unquote scientific way, but in particular ways that we seem to be familiar with. But then I said that this is not a definition, and Carl Linnaeus also did not give us a definition. So hopefully the medical dictionaries can provide some clarity, because they keep using race as though it's somehow a biological indicator of fact. But if we look at the Millikan Encyclopedia, it says a class or breed of animals, a group of individuals having certain characteristics in common owing to a common inheritance. I'll be honest, it's a bit weak. It doesn't provide specificity. And I don't think anyone becomes clear on what race is solely on that definition. We then look at the next definition in the American Heritage Medical Dictionary, a group of people identified as distinct from other groups because of supposed physical or genetic traits shared by the group. That's interesting, they use the word genetic. But they go on to say most biologists and anthropologists do not recognize race as a biologically valid classification, in part because there is more genetic variation within racial groups than between them. I'm going to say that again. Most biologists and anthropologists do not recognize race as a biologically valid classification, in part because there is more genetic variation within those groups than between them. Well, that just throws the whole genetic conversation up in a whirlwind. We then go to Mosby's Medical Dictionary. What does it say? 1, a vague, unscientific term for a group of genetically related people who share certain physical characteristics. Okay, again, also very broad and opaque. They say a vague, unscientific term for a group of genetically related people. Again, they're now using genetic. So if race is genetically related people, are they saying that race is therefore genetic? Well, Dr. Vassall, and what we'll show in a bit, establishes that no, it's not. Let me give an example, especially for this idea of that race is a determinant factor of one's physical health outcomes, right? There's an idea that race is genetic, and therefore we have certain outcomes like comorbidities that are increased in certain racial groups. And you see that through what some would call the disparity research, the racial disparity research. Disparity meaning just that there's a delta, there's a change, a difference in the numbers, right? It doesn't actually speak to why there's a difference. And that's why I tend to change the language and say, no, we're doing racial inequity research because there's a delta because of, as Dr. Vassall said, the way we treat people, not because of the color of their skin. But the example I was going to give is if it is dependent on race, and they're suggesting that race is genetic, then that means that if my race changes, my health would change. Well, then great. Let me go to a different country and get a different race. What do you mean, Edwin? Well, if I go to South Africa, by definition, I am colored. I'm a different race. I'm colored. If I go to Central America, I can be mestizo, I can be indio, I can be, because I'm from the United States, considered gringo. And gringo means that essentially you're an American. So if that's true, then does that mean my health becomes better just because I stepped over a border? No, absolutely not. That's absurd. So then race can't be genetic because it's socially and politically constructed, which is what we'll get to in these next definitions, right? One of the initial social definitions of race or sociological definitions of race was that it was a construction, a concept that has no objective reality, but rather is what people decided it is. Now that takes it to another spectrum, right? It's, well, you can decide whatever you want your race to be. The truth is we are very clear that yes, one may have a self-observation of one's race, and that determination also includes, whether for good or bad, the observation of society around us. And so a definition that I attempted to articulate that provided hopefully some clarity, and I'm still missing a word in there, and I'll say it for you, that race is a socially and politically constructed taxonomy based on perceived skin color and sometimes culture, with no scientific or biological determinacy, however, has been used for the purposes of allocating resources and can be used as a mechanism of creating racial and political solidarity. So it's complex. It can do multiple things at the same time. But if we go back to the beginning of it being socially and politically constructed, we look at here in the United States, who decides what race we are under the rule of law? Many of us who were born here got a birth certificate. On the birth certificate, race was designated on there. Additionally, you have the US Census where you get to choose. And those choices were laid out not by you, not by social scientists. It was laid out by the United States government under the US Census. And that's true for many countries around the world. That's why it's often very strange when, for example, under white, you have Northeast African, i.e. Egyptians, who are categorized under white, or Middle Eastern folks who are categorized under white, because it is a political understanding of race and not a social one. Dr. Vassall, I see you have your hand up.
Yeah, just a quick comment, Professor. This is very important, the socially constructed political and economic construct. You know, there's a medical condition called albinism. Albinos are people who don't have melanin in their skin. So they are white. Their skin is absolutely white. There are Black albinos in the United States because even though their skin color is not Black and they don't have melanin in their skin, they still come from that group. They still have some other features, their hair and their lips, that can be identified. So this idea that Black is just the color of your skin makes no sense. Just a comment.
Yeah, thank you, Dr. Vassall. And Joe here also makes a good comment. He says, I've heard that the census category for race used to be filled out by the census taker who often just guessed. And you're absolutely right. It wasn't up until actually the 1960s. It was the US Census worker that was designating the racial categories for the individuals that they went to go visit. You didn't get the choice. They chose it for you, as Joe's mentioning. After the 1960s, then you started to have the opportunity to choose race. But even then, the categories weren't clear. For example, Hindu was a racial category on the US Census in the 1960s. Hindu is not a race. It is not an ethnic group. It is a religion. You can ask. I had Hindu colleagues who have told me, Edwin, it's weird that Hindu was a race, but it's because the United States is ignorant in so many ways of people who don't live in the United States. And so that ignorance actually starts to be found in the way that we discuss and dialogue race, both in a social capacity, but in a global capacity as well. So good point. So we've established that race is not genetic. And let me hammer the point even more, is that if I take my genome and give it to a geneticist, and I ask them, could you please tell me what race I am? What do you think their response would be? Well, Edwin, and I'll tell you what it is. Well, Edwin, I can't tell you what race you are because there's no race gene. I can possibly, and we may be able to triangulate the geographic location of your genetic ancestry, but that doesn't decipher what race you are, because race is socially and politically constructed. And I give the example, right, of traveling to different countries. So if race is not genetic, then why in the world did physicians try so hard to put what I call pathologize race as the actual disease? And I'll explain what I mean by that, right? A lot of times pathology means it's the study of disease, the study of how a disease life cycle and mechanism works. But if we're saying that some diseases are only attributable to certain races because it's genetic, then what we're saying is that race is genetic, and therefore the race is the pathology. You can't cure it, right? It is an unmodifiable risk. One of the examples I'll give is Samuel Cartwright. Samuel Cartwright was a physician, studied under Benjamin Rush. He was also a surgeon and psychiatrist. But he wrote a report in 1851 that he called The Diseases and Physical Peculiarities of the Negro Race. And he created 2 psychiatric diseases that he made up. Now, on the face, you'd say, well, he's a scientist, he published this report, maybe there's some validity to it. And this is why I tell folks that as much as we would like medicine and biomedical research to be apolitical, the truth is for the longest time throughout the history of the United States, it has always been political. Samuel Cartwright, in doing this research, I put that in air quotes, this research in this report, he owned enslaved Black people on the plantation that his family owned, and he did the studies on those enslaved Black people. And he said one of the psychiatric diseases that only Black folks can contract was drapetomania. Some of you may have heard of it. And I'm not going to read it, but I'll paraphrase, because it is disgusting to read out loud, but I will paraphrase, where he effectively says, any Black enslaved person, who ran away from slavery to seek their freedom had clinically lost their mind. That they had lost it, because no one of right mind would do such a thing. And you see the prescription that he lays out to invoke violence, to add fear as a mechanism of keeping folks enslaved. The next one, what he called rascality. And he says it's from the careless movements of the individuals affected with the complaint, again, that only Black folks can contract, as they're apt to do much mischief, which appears as if intentional, but is mostly owing to the stupidness of mind and insensibility of the nerves induced by the disease. I get angry every time I share this slide, but I show it because we really have to understand where the foundation of these United States' biomedical beginnings occurred. And it was ugly. And it continues to be in many ways. But he says, but all of this is mostly owing, to the stupidness of mind and insensibility of the nerves. I'm emphasizing insensibility of the nerves because, and I'll ask folks, what does that mean? Insensibility of the nerves. Dr. Vassall, maybe you can help us out here. When you'll hear insensibility of the nerves, what would that usually mean?
Yes, that's an important point, because in medicine for quite a while, it was believed because of this that Black folks didn't experience pain at the same level as white people, and therefore they were not given as much anesthesia in fact, sometimes no anesthesia for surgical procedures that was given to white people for similar procedures.
Yeah, absolutely. And we'll talk more of even the differential care in pain management, right?
Yeah, in fact, personal story,
Please.
only in retrospect do I remember that I had dental work as a child, as a young person, with no anesthesia. Personally. Now I remember that now, but at the time, you know, you don't know, you're a kid, you know, your parents send you to the dentist unsupervised. You understand that you are in the hands of a healthcare professional, and it's something I didn't even bring up to my parents because I didn't know that that was not the way it was supposed to be. So I have personally had teeth drilled and fillings placed without anesthesia.
Wow. Wow. I'm going to sit with that for a moment because that is the real life example of everything we're talking about that many folks may think is far in the past, but we're actually saying it's existing in our lifetimes. Another component that I want to add in the way that we pathologize race, particularly Black folks, is, and I apologize for the haziness of the title, but here it says oppositional defiant disorder. I talk about oppositional defiance disorder because in doing some research, studying all these medical, quote unquote, experts of the time and trying to understand what other ways did they use race as the mechanism to create the other. And one is one that I think creates a direct lineage to the previous slide I just showed about drapetomania, right? It was, and rascality, folks who sought their freedom, who ran away from terrible conditions, who ran away from authority, who ran away to be safe and to be with their family and to no longer be enslaved, which in many instances only makes sense. But if we fast forward to today and we look at the diagnostic criteria of ODD, oppositional defiant disorder, some of you are familiar with it. This is a disorder that folks can be diagnosed with from psychological experts, psychiatry experts, and many times it occurs at an early age, at a young age, in elementary schools and middle schools and high schools. But I'm sharing this because if you look at the criteria here, this is from the DSM. This is the criteria they use to say whether someone should be diagnosed with oppositional defiant disorder. Often loses temper, often touchy or easily annoyed, often angry and resentful, often argue with authority figures, or for children and adolescents with adults, often actively refuse or defy to comply with requests from authority figures or with rules, often deliberately annoys others, or often blames others for his or her mistakes or behavior. So I get into arguments a lot with my psychiatry colleagues who use this mechanism, the DSM, for a number of different diagnoses. But I particularly look at ODD and I say, how in the world is this the criteria for diagnosing children with oppositional defiant disorder? Because what this sounds like is me. This sounds like me, not just in elementary school, it sounds like me today. Because when we're talking about entering and living in a system that has been violent for folks who look like me for generations, then it only makes sense that there's arguments or there's a defiance to comply with requests because those requests are violent. However, when you respond this way, you become the aggressor. And I've learned that the hard way. Even more interesting is these are also the mechanisms that the systems of whiteness use to become the victim of their own crimes, right? By creating the harm, by creating the chattel slavery, by creating the conditions that Samuel Cartwright had, and then creating a disease that someone can be invoked with, they become the victim of someone who runs away from slavery because they're losing out, because it caused them harm, because this person had clinically lost their mind. And what I'm going to make the point very clear, what I'm suggesting is that drapetomania has not died and left into the history book. It actually continues today, where we are clinically diagnosing our young Black and brown children and suggesting that they have a disease called oppositional defiant disorder, which leads to an increased likelihood of being diagnosed with other forms of psychiatric diseases, but in particular ADHD, and being diagnosed and put into special education, which the data shows us, if those three things are true, diagnosed with ODD, ADHD, and being put into special education, you are nearly 15 times more likely to enter into the criminal injustice system. This is not an accident. We are criminalizing our children for responding to conditions that are harmful to them. That is the direct cycle that I'm hoping that we are doing in this work, that we confront, dismantle, turn on its head and say, we're not doing this anymore. And yeah, Allison mentioned that Black children are expelled more often for this, absolutely. Joe Scher, sociology, has developed a theory called medicalization that explains the process of constructing a new disease. It sounds similar to what you're laying out. Yep, absolutely. I really appreciate the comments and what y'all are sharing. I'm definitely following them, but we're going to keep going for sake of time, and then showing what this cycle that you all are talking about plays a role in how it is not only exacerbated, it is cemented into the foundations. We have a physical anthropologist, Ernest Albert Hooton. He's not a physician, but he was a member of the American Eugenics Society. He also was a professor at Harvard, and he is one of effectively the founding intellectual members of what we know to be criminology today. Criminology being the foundational source of what much of our law enforcement engages in, at least to the theoretical framing of criminology. And I want you to see what he said in his speech at Harvard, responding effectively to the question of, well, why are some people more inclined to commit crimes than others? And they were talking about racial groups. And he says, quote, now, if you take a race of persons, this is his explanation, for one reason or another, I like that, for one reason or another, if you take a person, now we're talking about folks who were stolen from West Africa, right? So they like to obscure the truth. Now, if you take a race of persons, which for one reason or another has remained in a primitive state of culture in its own chosen habitat, and forcibly transplanted into a new environment in a complex alien civilization, you may reasonably expect that race to carry over its own patterns of behavior into its new surroundings. And he says, if savage behavior is criminal behavior, to become a criminalistic race, right? Let's go back to the pathologizing of race. What he is suggesting is that it is inherent, it is biological, that it's not that there's criminal behavior, it's that there's a race, i.e. a genetic derivation of people who are criminalistic. He goes on and says, and if there is inherent in any race a propensity, i.e. that it is biological for certain types of crime, these potential realities ought to be brought into the open in the case of the American Negro. It is not an accident that you have a society of law enforcement that perceives a particular group of people, i.e. Black folks, as the enemy or as the other or as a race of people that have a propensity for certain types of crimes. Dr. Vassall.
Let me point out that there's this diagnosis called excited delirium, or sometimes called agitated delirium. And you really only see this diagnosis in the context of law enforcement interaction with someone they're trying to subdue. And most of the time, it turns out to be a Black person, a Black male. It happened with Manny Ellis here in Tacoma, where they supposedly developed superhuman, and that is the term they so often put on the police report, superhuman strength in their attempts to to evade restraint by law enforcement. So this continues to go on. The medicalization of behavior and treatment and subduing, using ketamine and other drugs to restrain somebody who has this diagnosis of agitated delirium.
Yeah, thank you for that, Dr. Vassall, because it is absolutely true. And I have an example to share that there was an individual, a Black man, who was riding on Rainier Avenue on his bicycle, and he ultimately gets hit by a car. His femur was fractured. That individual was met by the EMT, was screaming in pain, and suggested exactly what you were saying, that he was losing it. And they thought that he was high on drugs. And they gave him ketamine to calm him down. Ketamine being, you can explain it better, Dr. Vassall, but ketamine effectively being a prescription or, go ahead, Dr. Vassall.
It's an anesthetic. Yeah. It should really only be used in the operating room.
They gave him ketamine, and it's also been used as a method to, especially if someone is ODing or they are high, to subdue the individual. And they gave him ketamine, presuming that he was on drugs. They asked him if he was on drugs. He said no. He was screaming in pain. They couldn't control the screaming because it was excruciating. Well, they come back to the hospital, and this individual is now truly hallucinating because he is on ketamine, because it can also cause hallucination. And because of it, this individual can no longer get a CT scan because the hallucinations and the inability to control one's body was preventing them to have a successful CT scan. But then to add to the layer of all this is where the racial exploration comes in, is that this individual, this Black male, has a white wife who showed up to the hospital. She was sitting in the room. And no one asked her why she was in the room. Not a single person. Until finally, a Black physician came in and said, excuse me, miss, why are you here? She said, oh, I'm his wife. No one presumed that this white woman was this Black man's wife. That she was just sitting in the back of the room for no apparent reason. They were ultimately asked, has your husband ever done drugs in his life? And she said, none whatsoever that I'm aware of. And what you see is that these presumed stereotypes that come to the front of the mind on a regular basis have detrimental effects to the patients in a long-term basis, because what ultimately happens is that if it comes from EMT to ER, and in the chart, whether verbalized or otherwise, it says drug user, that's why we gave him ketamine, that information is on the chart indefinitely until someone removes it. And who's going to be the advocate that's going to remove that, especially if, as a patient, you don't see it? You don't see it in your chart. We are going to fast forward to where are we at? I want to show another example of where race plays a role in equations. Dr. Vassall talked about the renal function, the kidney function, and that's what I fast forward through. But here's another example of what they call the VBAC equation. This is for birthing folks, birthing women, and the vaginal birth after cesarean equation effectively asked by the healthcare team that gets filled out. And if you notice the questions on there, it says African American, Hispanic. And if you click yes, it increases the likelihood of the calculator suggesting that you should have a cesarean birth. Because the data shows, and the data is accurate, the data shows that Black and Hispanic birthing folks and women have higher rates of C-section and complications during natural birth. But the weird part about all this is that the moment you click this calculator, the data from this goes back into the same data set. And so it's reinforcing the same belief that Black and Hispanic, Latina birthing folks and women have worse outcomes after C-section. And so they're going to ultimately have to get another C-section because the data is forcing the hand through this calculator. And I remember bringing this up to a colleague, and it was fascinating. I remember asking why. I said, well, because the data says that they have worse outcomes after C-section. He said, okay, that's fine, but are we saying it's because of their race? Well, no, we're not exactly sure why. Exactly. So it's not their race. Now, if we want to ask a question, and I say this to many of my colleagues, particularly those who are in primary care, the question we should be asking when we see our patients is, have you ever experienced racism? How have you experienced it? How can we support you in knowing that you've experienced it? Because the data is there, that it has deep psychological effects on the health and the biology of those compounded experiences of racism. Dr. Vassall.
Yeah, as long as we're talking about birth, I want to say something about the APGAR score. After this person delivers the baby, one of the first things they do is an APGAR score at 1 minute and at 5 minutes. APGAR stands for appearance, pulse, grimace, activity, and respirations to assess the health of the child, of the infant that is just being born. The first thing they look for is the color. You get 2 points if you are pink. You get no points if you're pale or if you're cyanotic blue or dark. So from the first minute that a child is born here and they're assessed, the first thing they look at is their color, and they make an indication of what that color is. And that is an indicator of how they will do. And Black kids often start out -2 on that scale.
Hi, Don. I appreciate the comment. And I know that is a clinical recommendation and the clinical guideline, but that has not been accepted, unfortunately, universally throughout the entire hospital systems. I know hospitals today that still use it, believing that there's sufficient evidence to uphold it. But I do hope that they get to the current clinical guideline that you shared with us. So thank you, Dr. Kopp, for doing that. And thank you, Dr. Vassall, for sharing. So the last thing I'll leave us with is, and this is a graph that I created, and it just hammers the point of everything we just discussed, that race is a social political identity. It's not a biological one. And these social political identities inform the forms of oppression that we may experience because of those identities: racism, sexism, cissexism, xenophobia, etc., which then lead to us understanding the access or inaccess of the social determinants of health: food, housing, education, employment, healthcare. And when brought together, when coalesced, those things most definitely have a physiological effect on our bodies. And ultimately, genetically. I have this blue little, I did draw this on my iPad, this blue squiggly line. And that line is for the future research of my hypothesis that there is a direct line between the social political identity and the biological identity, but only insofar that we are capable of measuring, which we are, and we are doing more work of, but the hypothesis that the compounding effect of experiencing racism actually, and this is a research that I'd like to do and working with folks to get through it, actually makes our microbiome, that means the guts, right? The microbiome susceptible to inflammatory diseases, which is all the comorbidities that we keep saying are disparities, right? High blood pressure, hypertension, type 2 diabetes. But when you look at papers and ask them, well, why is there a disparity? The response is, well, more research is needed to understand. And what I'm positing is that the reason there is a disparity is because our communities face higher rates of stressors, in particular racism, making our microbiome susceptible to these inflammatory diseases. And we haven't addressed that in any real way. And I think it's the next evolution of these conversations as the technology advances for us to be able to do that. And so I want to leave us there. I want to share the space with Dr. Vassall, answer any questions that may come up or any final thoughts that Dr. Vassall may have. But we're super grateful for your engagement, for your willingness to hear us out, and for engaging in this work with all of us, but we're hoping that you'll continue it as well.
Yeah, thanks, Edwin. Just a couple of things. First of all, thanks everybody for listening to us. We really enjoyed doing this presentation. I speak for both of us, I think, Edwin. A couple of things I want to make sure you understand, because Professor Lindo has talked about inequities and disparities, and they are different. Disparity means that there's a difference. And inequity means that there's a difference that cannot be explained other than by the way somebody is treated. Example, there's a disparity in the rates of breast cancer between men and women. It's different. There's a lower rate of breast cancer in men than in women. That is a disparity. It's a difference. We can explain that because there are physical and physiological differences between biological males and biological females in terms of hormones and physical structure. That's a disparity. And inequity is this, that within breast cancer, Black women are diagnosed later and tend to die sooner and diagnosed at a later stage of disease than white women. That is a disparity because it's a difference, but it's also an inequity because it can't be explained by a difference in physiology, a difference in hormone structure, or anything else of biological. So it must mean that that disparity, that difference, is due to something that is potentially correctable and potentially unequal, i.e. how they are treated, how they are diagnosed, when they get to the doctor, access to care. That causes an inequity. There's no biological reason why Black women and white women should have a different outcome for breast cancer. And the fact that they do is an inequity. So I hope that explains the difference between a disparity and an equity. The other thing I wanted to say, and Edwin has emphasized this over and over again, but I want to emphasize it again, is the fact that there are no genes for race. There's this very popular show called Finding Your Roots on PBS, where they have these people come together and they go through their genealogy, and they very often spring some surprise on them that they're related to somebody that didn't know they were related to. Throughout the show, though, they keep talking about European genes and African genes and South American genes. In the small print, they admit, if you look at it, that these are not biological genes, that they're population demographics. But the popular understanding is that this is a genetic journey that people are going on, and that this is biological. So we are still reinforcing this myth for its entertainment value, for its economic value, whatever, that there are biological genes that trace people racially, and that is just not the case. So that's what I want to leave you with, and then we'll open it up for questions.
Yeah, and please feel free to send questions in the comments, and as they are coming through, and we're grateful for all the words. They definitely keep me going and doing this work. I want to add that as far as keeping doing this work, you all are probably very aware. I'm actually sitting in an airport in the state of Florida. And I said, I can't miss this presentation. I will push the flight around and make sure that we can do this presentation. But the truth is that there is now a clear battle to even understand history, to even have this discussion, right? To be able to say the word. This whole presentation is grounded in critical race theory, and yet it is stigmatized and dogged as though somehow what we're trying to do is dismantle humanity, when in reality, what this work is speaking an absolute truth that is clear when you understand science, right, of what needs to happen and why racism is the true issue that should be pathologized and not our communities. When we can pathologize racism, then we are going to get much closer to the solutions that we haven't been able to find. But we've been distracted by so many other things. And at this moment, the distraction is just fighting to be able to teach African-American history, fighting to be able to say the word that we live in systems of racism. And if those are distractions we have to fight against, then it's true, we won't get to solutions very quickly. But I ask that we continue to be brave enough to say these things out loud, because there's nothing false or inaccurate about them. They are grounded in the absolute truth that when we get there, we can start moving to more creative and beautiful ways of thinking what health justice might look like.
Dr. Vassall, Edwin, thank you so much for sharing with all of us. For me, every single time I'm in the space with, even though it's a virtual space, every time I'm in the space with the two of you, again, reminded how much I have to learn. Reminded also, I think, that this work, it's important that we know the history and that we know a more robust history than what has been taught in many spaces, so that we can, as we think about whatever the new normal is going to become, it's important for us to know what that history is. And something that I've always appreciated about each of you is that you engage this work with precision. And in 2024, I think there's no, better time that we are engaging this work with precision. And to your point, Edwin, is that like there's no better time than now. Like this is the time for us to, we should have been having these conversations a long time ago. And also, I think it's important to recognize that people have been having these conversations for a long time, right? It's that unfortunately, at times, it's the power of the pen, right? It's the people who have had that power to write things that have been acknowledged as knowledge, as sound, right? That the illusion of objectivity within these spaces, for me, is something that I'm reminded of. So
we're grateful, and not to get you, I'm grateful for the center that you're sitting in and standing in, right? The Center for the People that WSU has put together. And for everyone listening to realize exactly what David mentioned, that your words are just as powerful. That can also be published. It doesn't have to be in a peer-reviewed journal. It could be a podcast. It could be a poem. It could be your art. But there's places like at WSU and that center that can allow these narratives and stories to be told loudly and proudly. And I just got to say, David, you look great in front of that camera. I feel like I'm like in a real show. This is amazing, but y'all did an amazing job.
Thank you, Edwin, and thank you, Dr. Vassall, too. I appreciate the words. Honestly, that for us, that is the focus of not only this space, the Center for the People, but also the conference, is that we recognize and we believe that people know what they need to be healthy. We believe that, and we know that people see, and that they don't necessarily, especially those that have been harmed, that they don't need to see all the statistics, right? They're experiencing, as John shared with his dental story, right? We recognize that for many, this is their reality and has been. So they don't need any convincing, right? Because they've experienced it. So as we think of the new normal and what this could be, I mean, what are some of your thoughts in terms of actionable items? Because I think that, there are times when, if we're digesting this important information, thinking about, it's kind of that conference excitement, right? We come, we hear new things, then what can we do? And so for those that are on the conference today, what is it from your perspectives, given what you shared today, that they can do as they walk away?
I'd be interested in hearing from some of the participants about that. But what we wanted to do is not so much have you learn a lot of facts and information, but understand some concepts and how to think about this, which is kind of why I talked about the curb cut phenomenon and how people think about disability, how people think about race, how people think about these demographics, and how to make sure you understand what you're talking about. As Edwin and I do, we understand what we're talking about, that you understand what other people are talking about, and that you can be so clear that when something is just not right, you can call it out and understand it. Very often people are talking and your BS meter is going off, so to speak, but you don't know how to call it out. You don't know how to exactly confront it. And I think understanding it allows you to confront it better. That's what I would say.
Yeah, absolutely. And I think that you mentioned the word that I like to sit in is how can we get as precise as possible, right? A lot of times we know the hurt of racism. We know what it feels like. And we think, oh, but other people have better words than I do, so I can't articulate it. And what I'm suggesting is, no, you got the words. It's that feeling that you have. But I want us to work on saying it out loud, practicing it, learning about it, hearing what we said, and digging more research. One thing I encourage so many folks to do is when there's something we don't know, oftentimes we're like, oh, well, I guess I just don't know it. And I'm saying, no, the moment you realize you don't know the thing, that should be the inspiration to say, oh, well, I'm going to spend the next 30 minutes, whether it's quickly on my phone or on Google, and I'm going to understand what it is it actually means, because I keep hearing this at work and my colleagues in the classroom, and I need to be able to defend the position of justice in a way that is clear. Because what we are in the middle of, what is I would argue, a war for what is just. And that war requires precision in the language that we use, because the language that we have is powerful. It is clear. We just have to be able to do it together in unison. And so it's coming to this, it's studying, it's reading, and you don't have to be the expert. You just have to know enough to say, I know that wasn't right. And I'm going to ask you to go do some homework, because that may cause harm to these folks. But that courage is a powerful place to be, and I think is incredibly important.
And I'm seeing the chat light up with all the things that people are sharing. And something that jumps out to me is just how interdisciplinary this space is. We have folks that are coming from different experiences, different professions, and that's actually what we're hoping to do. And as you shared, Edwin, like no one of us has all the answers maybe, but collectively, that there's an opportunity for us to come together and to create that and to share that wisdom in terms of how we're impacted and how our communities are impacted, and also the lens through whether it's our area of study or how we view the world, and how that can be utilized to make things better. Another thing go ahead, sorry. No, please.
I was going to say, no, the last thing I was going to say is to emphasize your point in the beginning is, how do we remove the ego of the individual in this work and we find the collective, because it is the most powerful thing we can do. It is absolutely the most powerful thing we can do. Critical race theory started that way. It didn't start with Kimberly Crenshaw. Kimberly Crenshaw said it started because a group of us said we were tired of sitting in law school classes that didn't talk about the racism that the civil rights cases were based on. And so we had to do something about it. We had to tell the truth out loud. But they did it in a collective, right? They brought 7, just really quickly, they did a little summer workshop with 5 faculty from across the country. None of the schools supported them, and they did it ad hoc. You know, what's funny and beautiful is that this feels very similar to that, right? That we're coming together and we're saying, let's build the coalitions that push the mechanisms that bring more justice to our communities.
Yeah, in that regard, this whole thing about the renal function, by the way, this came about, the change came about because there was a group of Black students at the University of Washington Medical School who said, wait a minute, this makes no sense. I'm not a doctor yet. I'm just a student, but I'm looking at this and I can't figure out how this makes any sense. So they went and researched it and went to their professors and said, hey, professor, this doesn't make any sense. And they had to turn around and say, you know what, you're right. And that caused an international change because now all the labs across the world are changing the way they report renal function. So yes, wherever you are, you can make things happen. As Professor Lindo is saying, you don't have to be a professor. You don't have to be teaching it. You can be a student. You can be a poet, as long as you have the brain power to say, you know what, this doesn't make any sense. I'm going to come to a different answer here. You can do that.
And the best line I heard, I was reading, no, it was Saul Williams. He had an interview, and Saul Williams, prolific poet, one of my favorites. He said, everyone has a lane, but the lane as the artist, the poet, is to remind you all why we're doing this work in the first place. And so even as artists and griots and storytellers, that lane is just as powerful as folks making the change on the equation or making the change in the policy. Like we have our skills that we can build on. And when we know that, it's a beautiful thing. It's a movement. And the movement is a hard thing to stop.
Again, I get overwhelmed just by, being in the space with you all and just having this conversation and continuing to build on what we know needs to be done, right? One of the things that I always appreciate about listening to both of you and the way that you engage the work, not only with precision, but for me, it is refreshing to see this be presented in a way that honors people's humanity, right? And I think that oftentimes when we look at data and when we look at research or reports, oftentimes it describes what we don't have or what people are doing wrong or why people are bad or whatever, whatever the context or the inferences that are expected to be made from that. And, and talking a little bit about humanity, I guess for me, one of the things that I'm always interested, especially within this work can be taxing. I mean, if there's Edwin, you talked about the war, the fight, just how much it can take on especially on certain days and sometimes quite often. And so for me, one of the things that I always think about is like, what brings me joy? Like what, not just optimism, but what brings us joy? What brings us not just that hope, but what are you seeing that just excites you about where we're at and where we're headed? Because I also think that oftentimes the narratives that are told are told through the lens of deficit, right? And there's so much beauty and power in the people and in our communities that I think it's important that we always return to that.
What do you think, Dr. Vassall?
Well, David, anytime I talk to you, I get inspired. I really do. Your mind is always moving. You're always thinking about the next thing and how can we move this work forward. And I really appreciate you inviting me to this conference as you have invited me to others nationally so that I can interface with others who are doing this work. That's what is exciting to me. And certainly what's exciting to me is what students are doing, what young people are doing, what people are doing who are coming after us and who we're passing the baton to, because there's a lot going on there that informs us and keeps it relevant and keeps it exciting for me.
No, I think that's absolutely true. What I would add is, well, I'll tell the story of a project that me and my partner and wife, Dr. Estelle Williams, are a part of, which is Estelita's Library. And we're talking about a community social justice library that started in Beacon Hill. We're now in the Central District in Seattle. But our premise from the beginning was to decolonize space and decentralize knowledge. that what we learned in these schools should not be isolated and should not be kept secret from our communities. And we said, well, all the books that I read in law school, I'm going to bring them into the library. And I want to make sure everyone has access to them. We also have one of the largest collections of the original Black Panther Party newspapers. And we said, how do we digitize? So we're in the process of doing that. But I'm sharing that it came from an idea. It was literally an idea sitting with our toddler, Estella. That's who we named it after. And we said, how do we create a community space that built love for each other, that raised each other? And we, one night, got keys to the initial spot from a friend of ours and said, yeah, I'm not using it. I used to rent it. I'm not using it. Do what you want. The next day, at midnight, we got wood from Lowe's. We hung up the wood for the shelves, put all the books in the shelves, and 300 people showed up to the opening. That was 2018. So from wooden shelves on a wall at an old coffee shop with books from our library to 2024, where we received a grant to purchase land in Beacon Hill, where we are ultimately going to build housing for our community. 70 units of housing with the cultural space on the main floor, and working with institutions to say, how do we change the model of on-site care in housing? And we're saying, what does a home visit look like in Beacon Hill? What does a pediatric visit look like when you can get cafecito or coffee when your parent and the doctor can see your child where you live? And it's not that these are new ideas, is that, and this is the last point that I'll make, is for the longest time, we have been told that our peoples, our communities are not advanced enough, right? Not smart enough. You have to work twice as hard. And I was convinced of it. Believe me, I worked twice as hard. Dr. Vassall worked 6 times as hard. And it's not that we're not good at that. It just means that we were taxed for that time we spent because we didn't get paid for 6 times more work. He got paid for the 1x work that his white colleague was doing, but was getting promoted twice as fast than he was. And what I'm suggesting is that our technologies existed over centuries. Our technologies is that we've been able to hold on to culture and stories and palabra. And that technology is that your grandmother can teach you how to give birth because she did it in the woods with her auntie. And that we have always had the technology because ChatGPT and Google, they can't keep culture. They can't, but we can. We have continued to. And I'm asking us to make sure that we realize that our technologies are in our words, are in our minds, in our imaginary of the future of what justice looks like. And when we hold that, we don't have to look into the future because our past already told us what the answers are. And we just have to do that. So going back to home visits is not that it's innovative, it's that we left it in the first place. That was the wrong move.
Yeah, and I know we're getting short on time, but Professor Lindo mentioned the Black Panther Party on it. So I must say another thing. Going back to the curb cut thing where these activists put these ramps in to benefit one demographic, but it benefits everyone. The Carolyn Downs Clinic is the last, it's in Seattle, it's the last remaining healthcare facility started by the Black Panther Party. And I was on that board when that clinic was started. And at that time, we also had a free breakfast program and a free clothing program. That free breakfast program that started by the Black Panther Party is now why they have school lunches across the United States. The Black Panther Party recognized that kids who were hungry weren't going to learn, so they started feeding them. And somebody said, you know what, this is not a bad idea. We ought to do this for everybody. So these ideas that you start, I'm talking to everybody on this call, can be disseminated and can become part of what is accepted by society. And that's why we do this work. So thanks.
Edwin, Professor Lindo, and Dr. John Vassall, thank you so much again for sharing.